So obviously the other aspect of dealing with the hip pathologies is when you have too much of varus angulation, what do you do? You go ahead and do a valgus angulation, and that's what you want to restore the femoral neck shaft angle as described. Why do you want to do it? Because it reduces the lurch, it strengthens the abductor mechanism, and reduces the trochanteric impingement, which is caused by an excessive varus, either due to a natural cause or an acquired cause, which could be post-operative. And it's very important to restore the ATD, as otherwise this becomes painful and osteoarthritic in later life. And it has the added advantage that it gives you length as well as with the surgery that you do. Indications, as I've mentioned here, it could be basically for a congenital coxa vara. This may be a sporadic occurrence or associated with a lot of syndromes, or an acquired coxa vara, which we see much more often in day-to-day practice, like in a fracture neck femur non-union, or septic sequelae, which is still the scourge of our nation, sometimes metabolic bone problems, and trochanteric overgrowth when you have failed to do a trochanteric epiphysiodesis for the Perthes treatment. Many ways to skin a cat. You could use either your standard DCP or the proximal femoral LCP, as Alric has already shown you, which has an inbuilt design. You could do it fixator assisted depending on how much control you have on your proximal segment, or you could do a pediatric DHS in select situations, or essentially in some septic sequelae when it's not possible to reconstruct a neck shaft angle, then what you go ahead and do is an Elizarov hip reconstruction, which in essence is a pelvic support osteotomy, but it achieves a valgization and therefore restores the abductor biomechanics. You could do the same thing using a LRS also. So depending on what you're well versed with, you could use any of these implants to achieve the above. So let's look at just a few practical examples of how this is done. The classical VY valgus osteotomy, as has been described. The pre-op planning is right there for you to really look up and read. But what you must make sure is that the angle of the wedge, or the amount of the wedge that you remove, is corresponding exactly to the Hilgenreiner's epiphyseal line and the horizontal as drawn from there. So that's to show you intraoperatively how this is done. After you have done your paper tracing and planning, you pass the K-wire, which goes absolutely parallel to that angle, and you remove exactly that much of a wedge as you had planned preoperatively there. You take out the wedge and then you use a bone hook and get the proximal fragment down. And as you can see over there, that's a lovely restoration of the normal neck shaft angle, and then you go ahead and fix it with the DCP. That's to show you some intraoperative pictures of the same. That's the amount of the wedge we have removed, which I showed you on the CM shots. That's the fixation. Immediate post-op pictures, 6 months later and after implant removal. And this has absolutely restored all the biomechanics, has given back the tension on the abductors, and the patient goes on to do well. In situations like this, when you may find it very difficult, or you have really too much of a varus and you may not be able to actually achieve the Powell's angulation, that time you go ahead and use a fixator guided valgization. The important part is you must get both your proximal pins absolutely parallel into the trochanteric or the proximal segment, and this is very often easily done by hyper-adducting the limb on table. You use next 3 Schanz pins down there, and to clinically show you there, and then you connect the whole construct with a frame. So just to take you through the intra-op pictures, that's your first Schanz pin out there. You go ahead and then pass the second one, and that's the marking of your osteotomy. At every stage, this has to be done under C-arm control. And once you have done that, the amount of valgus that you need is going to be achieved after you do the osteotomy. So make sure that you have all 4 pins parallel at the end of it, because this LRS is a very unforgiving implant. And this converts the vertical line, the pseudoarthrotic line there, into a horizontal, much more horizontal line, and achieves compression as well as valgization and tensioning of the abductor mechanism. So that's the post-op follow-up. And the long-term follow-up after implant removal. The LRS is a very easy implant to remove and much less morbid when you go ahead and do that post-operatively, and that's the lovely restoration of the neck shaft angle as done by LRS. The same thing again achieved by the proximal femoral LCP. Like he showed you very elegantly, 2 methods. It was a 9.5-year-old boy with a developmental coxa vara. The neck shaft angle was 95 degrees and the HE angle was 70, and that's the adduction X-ray, which you must do as a prerequisite, as he told you very beautifully preoperatively. That's the insertion of the first antiversion wire. And then your two main guide wires are absolutely parallel to the same, performance of the osteotomy, and the design of the plate itself giving you a beautiful valgization on table and a lovely neck shaft angle, restoration of the HED and tensioning of the abductor mechanism. That's a 1-year follow-up of the same child, and this goes on to do very well, and functionally the child is very good. Sometimes in septic sequelae, you have something which is known as a pseudovarus, where you simply have a problem of the trochanteric overgrowth. And this is very easily achieved by just doing a distal trochanteric transfer. This is not really a true valgization, but just mentioned here for completeness. However, in septic sequelae, very often you may have situations where you actually have a very, very short neck, and then you have to add in a bone graft, and you have to do what is known as a Mosher's triple neck lengthening osteotomy. This is a little more complex, where you need to remove a segment of the bone just below the greater trochanter, again using your same guide wire pins. That bony fragment itself is put back into the, after getting a hold into the proximal fragment, and you need to fix your plate over it, which gives you a full achievement of the neck shaft angle and actually lateralizes the shaft and gives you a TD correction as well. So just to show you a quick example, a severe septic sequelae with a coxa breva and a very severe high riding trochanter there, treated with a Mosher's osteotomy. The overgrown trochanter itself, chunk of that bone removed there, shaft lateralized, fixed with a DHS, and the trochanteric fragment again refixed, giving you a lovely restoration of the neck shaft angle. Septic sequelae pseudarthrosis, again issues are the severe lurch, varus, and you can see clinically the child is also showing a Trendelenburg positive sign. Those are your traction and adduction abduction views, which you must do to confirm whether there is movement at the pseudarthrotic site before going in. And when it shows you frank movement and again a very huge trochanteric overgrowth, you must go ahead and do the valgization osteotomy. Again, we used a pediatric DHS in this. The only difference here is that we did not take out a chunk there, and we just simply used hyperadduction out there to achieve again the neck shaft angle. In case of fracture neck femur, non-union, just treated with a CRIF, and the screws were not holding, and eventually had cut out, you had a gross neck shaft varus there, and this had to be done, a subtrochanteric osteotomy done at a lower level and fixed with a pediatric DHS. Compression and adduction achieved, restoration of the neck shaft angle achieved, union and consolidation at 3 months post-op, and a very, very good articulotrochanteric distance, and that's the kind of function you can get at the end of 6 months. In unsalvageable situations, this is not something which I am very familiar with. However, it's basically an essential PSO, so I would do it with a pediatric or a DCP, but there are situations where ILRS or Elizarov hip reconstruction can be done very easily. This has been elegantly described by Dror Pele. We won't go into theory for lack of time, but just to show you a case example, a 13-year-old boy with a post-septic complete destruction of the femoral head and neck, and this was treated with valgization osteotomy, or rather a pelvic support osteotomy, as you can see out here. And this was fixed by an orthofix and lengthened further. So it gave you a brilliant support at the pelvis there. It restored the biomechanics by tensioning the abductors, and that's the kind of function he had later. And the same thing again, a similar case example, courtesy Dr. Alaric. Elizarov hip reconstruction done, the shaft valgized there, abductors brought down, and lengthening achieved, and that kind of function at the end of 2.5 years. So in summary, there is many, many techniques to really achieve a good neck shaft angle. There is a very significant learning curve. You need to plan according to the age and indication. The earlier you do, it is better because it helps to reduce the weakness of the abductors. And you can, using the modern fixation methods, you can really immobilize them very, very fast. PSOs, I would caution, tend to remodel over a period of time. So the younger you do the child, you must counsel them in advance that this will need a revision at a later date. And I would only advise the younger surgeons to really embark upon them after a lot of careful planning and a lot of experience and apprenticeship. Thank you.